Shall we start? Yesterday, you guys gone through the disorders of adrenal gland. Today, we go on to the treatment for the different disorders of adrenal gland. So again, the end of the lecture, you should be able to describe the management of common adrenal gland disorders, relating it to their pathophysiology. So first of all, we go through Cushing syndrome first. This is the slide from yesterday. Before you learn what is the treatment like for a particular disorder, you must know the etiology. What are the different etiologies of this particular disorder? Then you can target it to the treatment types. Okay, so this is what I explained yesterday. The treatment goals for Cushing is to normalize cortisol level and treat comorbidities associated with hypercortisolism. In Cushing's, there's too much of cortisol. So your treatment aim is to reduce the production of excessive cortisol. Okay? Now, surgical management is the first line treatment option. Whenever possible, do surgery for the patient, okay, under the correct circumstances. So you resect the primary lesion. It depends on So for whatever tumor that there is, whether it's a pituitary tumor, ectopic tumor, or adrenal tumors, you resect it whenever possible, okay? Unless surgery is not possible. Of course, surgery is not possible in a variety of conditions. Patient is unstable, the tumor is somewhat dangerous, it impinges on some important structures, for example, okay? Or if it's unlikely to reduce glucocorticoid excess, but this is always the first line treatment. Complete surgical resection of the associated tumors is the optimal treatment because it alleviates hypercortisolism. Once you remove the tumor, there's nothing there to induce the production of cortisol, right? And it will restore the HPA axis back to its normal. So in benign unilateral adrenal disease, we're talking about a unilateral adrenal adenoma or tumor. It's curative in nearly 100% of patients, nearly, okay, with cortisol-producing adrenal adenomas, and it's usually done via trans or retroperitoneal laparoscopy, okay? Adrenal cortical carcinoma, okay, it's malignant carcinoma, as its name suggests. It has poorer prognosis, obviously, because it's a carcinoma, as compared to adenoma, which is benign, okay? So poorer prognosis is seen, especially in unresectable tumors, whereby the survival rate is up to 80%, even if you completely resect it, okay? Usually via transperitoneal laparoscopic adrenalectomy or open surgery, okay? Open surgery because sometimes the surgeons would want to have a better view of the peritoneum. You want to look at metastatic deposits, okay, or extension of the carcinoma, okay? Chemotherapy and adjuvant radiotherapy may be needed. It depends on the staging of the patient as well. Bilateral adrenal disorders, both sides, okay, bilateral. So what we can do is potentially bilateral adrenalectomy, whereby rapid and definitive control of hypercortisolism can be done. However, patients, because you already removed both adrenal glands, so there are no adrenal glands, adrenal tissue to provide you with all the hormones required. So the patient would need lifelong glucocorticoid and mineralocorticoid replacement, okay? So this has to be done with caution after careful thought and also discussion with the patient, okay? Now, this is not included in your slides, but I just want to show you. Some of you might be asking, what is the transperitoneal approach? What is the retroperitoneal approach? So for laparoscopic surgery, it is as such. Of course, the surgeons would know better, but basically retroperitoneal is you want to remove the adrenal gland or the tumor from behind, okay, retroperitoneally. Of course, your area of surgery will be much smaller, but reports have shown that it has improved the outcomes, okay? As for ectopic ACTH secreting tumors, the outcome would depend on the presence of metastatic disease and also where is the ectopic tumor located. It can be anywhere, right? And resection with node dissection needs to be done. For Cushing disease, what we do is a transsphenoidal selective adenomectomy, meaning that we want to remove this pituitary adenoma. So transsphenoidal, they go through the sphenoidal space and they go directly to the pituitary gland where the location of the tumor is. Of course, it is not without complications, okay? So you might have electrolyte imbalance because if you damage the pituitary gland, you might damage the production of all the anterior and posterior pituitary hormones, right? Hypopituitarism, okay? Hemorrhage, meningitis. So complications would, one that we fear of is hypopituitarism, especially, okay? Now, glucocorticoid replacement post-surgery. So saying that that patient has successfully gone through a surgery to remove the tumor. After a successful surgery, you don't expect the HPA axis to be immediately recovered. Okay, so you need glucocorticoid replacement until the HPA axis recovers. And this will take approximately 6 to 12 months after resecting the ACTH producing tumors. If it's adrenalectomy, adrenal tumors, usually need up to 18 months. This is just in general. Okay, so the clinicians would have to monitor their blood results during each follow-up. Okay, hydrocortisone is the preferred glucocorticoid due to its shorter half-life. Okay, glucocorticoids with longer half-life may prolong the HPA axis suppression, so it has to be given with care by the endocrinologist in charge. Okay, follow up with morning cortisol or ACTH stimulation test to assess the recovery of the HPA axis. Okay, glucocorticoids obviously can be stopped when the test resumes normal. Usually, it will take months to years. Okay. Now, second-line treatment options. If surgery cannot be done for these patients, what are we going to do? So, in patients with ACTH-dependent Cushing syndrome who are unable to proceed with surgical resection or their initial surgery failed due to whatever reasons, operation problems, patient had a lot of comorbidities, were unfit for surgery, etc. Now, there are several options which are available. Number one, they can do a repeat transsphenoidal surgery. That means the surgeons must be confident enough, they go in again and they perform the surgery. And this can be done in patients who usually have no comorbidities and they find that the surgery was not too hard, but the tumor resection was incomplete the first time. You cannot confirm complete resection of the tumor when you're on table most of the time because you would need to resect the tumor, you send it for histopathological analysis, and they will look at the margins under the microscope, whether the margins are complete. Okay, so most of the time the confirmation is after the histopathological report comes back and say, oh, this is a complete resection or incomplete and things like that. Okay, but when you go in for surgery the second time, there's increased risk of hypopituitarism because you are going near the pituitary gland, you are causing harm to the pituitary gland for the second time. Increased risk of hypopituitarism, alright? Radiotherapy can also be done in patients who failed surgery or have a recurrent Cushing's disease. Somehow, many years later, they get another adenoma, even after the first adenoma has been resected, for example, okay? But medical therapy must be proven effective to normalize cortisol before radiotherapy as the effects are delayed. Okay, so radiotherapy effects are not, oh, you are doing radiotherapy today, the next day you are fine. It's not as such. The effect takes months to years. Okay, so you must have concurrent treatment at the same time while awaiting for the outcomes from the radiotherapy. Okay? Medical therapy can also be given. Medical therapy to be administered post-transsphenoidal surgery in certain patients as a primary treatment in patients with ectopic tumors, especially when you have ectopic tumors which are all over the place or at some place where surgical resection is impossible. You need to give medical treatment to these patients, okay? Occult tumors, tumors that you know are present but somehow you are unable to localize it via scans. You know it's present based on your biochemical investigations. But from scan or imaging, you are unable to localize the tumor. Sometimes they're very small, or even if you use radioisotope scans, the uptake is very little, so you can't distinguish it from the normal tissue, for example, occult tumors, okay? And you can use medical therapy as an adjunct in adrenocortical carcinoma in cancer patients, okay, where surgery is not a treatment or has failed, for example. Bilateral adrenalectomy, okay, can be done, meaning you remove both the adrenal glands. Again, this is a very drastic measure because both adrenal glands are removed. You have no more adrenal tissues left, okay? This can be done in patients with occult or metastatic ectopic tumors or as a life-preserving emergency treatment for severe cases. And besides not having adrenal tissue later in life, the patient also has a risk of developing Nelson syndrome. Have you heard of this before? Basically, it's a rare disorder whereby some of the patients, you remove the adrenal glands bilaterally so that the effects of hypercortisolism are not seen because the adrenal glands are no longer there to produce cortisol, right? But the ACTH production is still continuous. So it can actually cause enlargement of your pituitary tumors, okay? So the pituitary tumor might grow large and cause compressive effects, okay? And subsequent effects like vision loss. It may also be too big to cause pituitary failure, etc. Okay, so Nelson syndrome. Now, these are the types of medical treatment I've mentioned earlier in this slide, okay? So medical therapy, so these are the examples of medical therapy that can be administered by the endocrinologist. So the first two drugs, pasireotide and cabergoline, they mainly act at the anterior pituitary gland, okay? And then you have adrenal steroidogenesis inhibitors like ketoconazole, methylrapone, mitotane, etomidate that acts on the adrenal glands itself, meaning they inhibit the production, the release of these hormones. And also you have mifepristone, which is a glucocorticoid receptor blocker. What it does is that it binds to the receptors to prevent the effects of cortisol. Okay. You do not need to know this in detail. I put this in so that just in case you want to know, okay, mitotane, how does it act, at which pathway? If you're interested to know, this is one of the diagrams which is available in the journal, and so are all the other drugs. But basically, as a general guide, you just need to know, okay, these drugs, they block the production at the pituitary gland, okay, as such. You need to know in general. Okay, so for steroidogenesis inhibitors, okay, I just listed down a few of the adverse effects. Of course, the adverse effect list is very, very long, okay, if you look at the product insert, okay. Ketoconazole, adverse effects, GIT disturbances, nausea, vomiting, okay, anorexia. You have hepatic dyscrasias, you have deranged liver function tests. Some people might get meal hypogonadism. Methylrapone, you have side effects, hypokalemia, hirsutism. Different drugs, they have different side effects, and the risk is also different as well. Mitotane, primarily for adrenal carcinoma, the treatment, and you also get all these side effects. It's not usually given because it is teratogenic, only for certain cases. Okay? Pituitary directed ones, we have cabergoline, as what I showed you in the diagram just now, pasireotide, and also mifepristone, which has anti-progestin effects. So all these, what I'm just trying to show you is that medical treatment also comes with its side effects, and side effects differ based on the drugs that are given. So when the patient comes for follow-up, patients who are on these medications, the side effects need to be monitored. For example, if the patient is on ketoconazole, you need to monitor the liver function test. You need to monitor the other hormones, the fertility panel, and also GIT. You need to monitor whether the patient has GIT problems, and you need to administer medication for that if needed. Okay? Adjunctive management. This is very important. A lot of the endocrinological management is a multidisciplinary approach. It involves the nursing team, the pharmacy team. You need to have the endocrinologist, the surgeons, the anesthesiologist. Okay, multidisciplinary approach. Okay, first of all, education to patients and their family about their disease, treatment options, and what to expect. Because they do not know anything about the disease, you have to explain to them as doctors later in the future. Okay, what is this disease about? How are we going to treat you? Surgery or medical treatment? After treatment, how fast would you expect to see an improvement? How long do you need to follow up with us? What are the possible side effects and complications of the treatment given? So all these you need to be able to explain to the patient. You need to evaluate the patient for risk factors of venous thrombosis and perioperative prophylaxis for venous thromboembolism. So patients who have undergone surgery would have a high risk of VTE, as you all know, venous thromboembolism. So you need to give prophylaxis, okay? And you need to explain to the patient why the patient needs to be on this prophylaxis, okay? Treatment of cortisol-dependent comorbidities. So the patient not just only has a hypocortisolism, they have complications associated with hypercortisolism, which I've already explained yesterday. So they might have psychiatric disorders, they might have diabetes, hypertension, hypokalemia, osteoporosis, increased risk of infection, dyslipidemia. There's so many things just because they have a pituitary adenoma that secretes ACTH, right? So you need to treat all these related comorbidities as well. So if the patient comes in with Cushing's disease, you need to not only plan for the surgery, you need to treat all these things before the patient goes for surgery. Control the diabetes, control the high blood pressure, control the high dyslipidemia. If the patient has psychiatric disorder, refer them to see a psychiatrist, start them on medications, things like that. So it's a holistic management. It's not just, oh, treat the high cortisol. Of course, that's the main treatment, yeah? Administration of age-appropriate vaccinations as they have an increased risk of infection. So it's depending on the age group of the patient as well. Now we go on to Conn syndrome. Again, the causes, as what I've told you yesterday. Treatment goals. So for Conn syndrome, normalization of blood pressure, normalization of serum potassium, normalization of aldosterone levels. This is the treatment goals, okay? The main treatment goals. So again, what do you want to do with this? Surgical management is to be considered in patients with unilateral primary aldosteronism. For example, they have an adrenal adenoma, okay, or unilateral adrenal hyperplasia. So they can undergo either a laparoscopic surgery or an open surgery. Okay, the type of surgery is under the jurisdiction of the surgeon, obviously. The surgeon will assess the patient and see which one is better. Okay, of course, a laparoscopic surgery, because you only have small incisions, okay, smaller risk of infection, bleeding, okay, and that's why you have shorter hospital stays and generally lesser complications. Okay, post-adrenalectomy, okay, what you need to do. BP and serum potassium concentrations improve nearly 100% of the patient, obviously because you have already removed the tumor. A significant and sustained reduction in left ventricular mass index, because the heart is not doing so much work to pump blood already. Hypertension is also being improved, okay? So you have reduction in left ventricular workload. You also have a reversal in the carotid intima media thickness, arteriosclerosis is all observed because the hypertension is somewhat corrected in that sense. Pre-operative management. Hypertension and hypokalemia should be controlled before patients undergo surgery. Okay, you know that patients with Conn syndrome, they have hypertension because of hyperaldosteronism. They also have hypokalemia. You obviously can't send the patient to the operation theatre when both of these are not controlled. So you need to manage them first. After surgery, now you control the potassium, you control not just the potassium, the electrolytes, sodium, etc., whatever that is abnormal. You also control the patient's hypertension. Then the patient goes in for surgery. Post-surgery, how do you manage the patient? Okay, so you need to give post-operative IV fluids, normal saline without potassium chloride, unless there's persistent hypokalemia, because you would expect that the patient would get back to the normal physiology already once the tumor has been removed. Okay, potassium supplementation and mineralocorticoid receptor antagonist should be withdrawn because you don't want the patient to get hyperkalemia after that. Okay, antihypertensive therapy, the patient usually is on some form of antihypertensive therapy. It should be removed gradually post-surgery because you would expect the patient's BP to get back to normal. A few weeks after surgery, a generous sodium diet is recommended to avoid hypokalemia that can develop from hypoaldosteronism due to chronic contralateral adrenal gland suppression. So you have to monitor the blood results before you decide for that. Okay? Measurement of the aldosterone and renin to see what is the ratio like post-surgery. So the BP typically normalizes between 1 to 6 months after surgery, so you can gradually taper your antihypertensives. Persistent hypoaldosteronism requiring mineralocorticoid replacement therapy may occur in up to 5% of patients post-treatment, just for your information. Okay? Now, if surgery is unable to be done or for whatever reasons, medical treatment is to be considered. Okay? Patients who are unable to undergo surgery, very old patients, a lot of comorbidities, refusal for surgery. Okay, you see a lot of this during your clinical years. Patients with bilateral adrenal disease, okay, aldosterone producing adenomas, glucocorticoid remedial aldosteronism. Conditions like that, bilateral adrenal disease, are you going to remove both adrenal glands? Okay, so medical treatment is to be given in these patients. Treatment would be mineralocorticoid receptor antagonist. I think in the lecture notes I gave, I typed wrongly as agonist. It should be antagonist because you want to stop that, right? You want to inhibit that. So, example would be spironolactone, eplerenone, amiloride, and triamterene. So I show you what is the mechanism of action here. Okay, I don't have my pointer, it's out of battery, but just to show you, the orange circle there is the epithelial sodium channels. Okay, you have your aquaporins, also you have your aldosterone receptor. This is towards the distal convoluted tubules, down to the collecting tubules of the kidney. Around that region, you have your principal and collated cells. So usually what happens is that sodium is being reabsorbed there. The aquaporins will take in water, okay, and what happens when you have amiloride or triamterene, okay, it directly blocks these epithelial sodium channels. So you don't have any sodium reabsorption, okay? So that is one of the effects that it's trying to mediate. And if you're on spironolactone or eplerenone, okay, they are competitive antagonists, meaning they compete with aldosterone to bind with the aldosterone receptors. If you have this drug, less of the aldosterone will bind to the aldosterone receptors because they compete with it, right? So they prevent the action of aldosterone when you are giving these drugs. Okay, so what are the differences between spironolactone and eplerenone? Spironolactone is the first generation antagonist. Okay, it has very high affinity, it directly blocks. Okay, so, and it's non-selective. It binds to everything that has mineralocorticoid receptors, okay, including testosterone receptors binding to androgen receptors. So it has more side effects because of its non-selectivity. Eplerenone is a second generation antagonist, so it has lower affinity to the receptors. It is more selective in the sense that it only competes at the aldosterone receptor. Because it is more selective, it has lesser side effects. Of course, one of the disadvantages, it is more expensive. Okay, so it depends on whether your hospital has budget to purchase this medication for your patient. Okay, a little bit about glucocorticoid remedial aldosteronism. I've told you that this is an inherited disorder. So you can't really do anything about it, right? So what you can do is you treat medically with glucocorticoids. Okay, they are ectopic production of all these tissues that secrete cortisol. So what you do is you give glucocorticoid. For example, dexamethasone, prednisolone, the long-acting ones, to suppress the ACTH production. So this is what you can do, okay? But this condition is rare, okay? We go on to congenital adrenal hyperplasia. So back to this familiar diagram again. You need to know where the blockage occurs, where's the deficiency. So, medical treatment in classic congenital adrenal hyperplasia. Glucocorticoid treatment prevents adrenal crisis and virilization to allow for normal growth and development. As you know, a lot of the cases are diagnosed in childhood, okay? So you can give different glucocorticoid types. There are short-acting ones, intermediate-acting, and long-acting ones. So mineralocorticoid treatment maintains intravascular volume and salt balance because mineralocorticoid acts like your aldosterone, isn't it? It pulls in water and salt to maintain your effective arterial blood volume. In newborn or infants, mineralocorticoid requirements are higher, hence sodium supplementation is commonly used. Okay? And in children, hydrocortisone is the preferred one because the shorter half-life minimizes the adverse effects of longer acting or more potent glucocorticoids. Okay, but the treatment changes. So the endocrinologist will look at the patient's compliance to medication as well as the effects. For example, if you are giving short-acting glucocorticoids, you need to take more doses, isn't it? So if the patient is not compliant, the endocrinologist might change to a longer-acting one, for example. So in adults, daily hydrocort or long-acting glucocorticoids are given together with mineralocorticoids. Okay, so what is important is you have to balance between over-treatment and under-treatment. Okay, so patients who are on glucocorticoids and mineralocorticoids, be careful not to give too much or too little. Too much, you get side effects of excessive cortisol and mineralocorticoids, okay? And if you give too little, you get effects of adrenal crisis, you get effects of low hormonal effects such as adrenal crisis, okay? Conditions, signs and symptoms that look like Addison's disease, okay? Because you have less mineralocorticoids, you also have lower BP because you have lower effective arterial blood volume as well, okay? So it is always important that the treatment has to be balanced. So the dose has to be titrated each time the patient comes for follow-up after reviewing the blood results, okay? Stress dosing. Now, patients with severe CAD cannot produce sufficient cortisol in response to stress. Okay, you know that it's a form of adrenal insufficiency. So during these episodes of stress, if the patient is having an acute infection, the patient is having post-surgery, the patient has experienced dehydration, major trauma, usually the doses will need to be increased so that the patient does not get into adrenal crisis. Okay, and the clinician would need to increase this dosage. Monitoring, okay, for pediatric patients, okay, this is the suggested monitoring guidelines. Of course, guidelines will change from time. By the time you graduate, probably the guidelines would have changed again. So you need to go through the new guidelines during your time. So it is advisable to have close monitoring the first 3 months of life and every 3 months thereafter, because the patient is at a very fragile age, okay, and you want to monitor closely so that the patient has adequate growth. Once the condition is stable, more than 18 months, you can monitor every 4 months, and during each monitoring, you need to assess the patient's growth velocity. This is a PEDS patient, right? How tall the patient is, the weight, the blood pressure, annual bone age assessment to see whether the patient is growing with age until near adult height is attained, and also screening for testicular adrenal rest tumors in males after 10 years of age. What is TARTs? Testicular adrenal rest tumors, TART. Have you heard of it? This is something that can be seen in male patients with CAH. So they have some small tumors in the testes, okay, that are of very similar to the adrenal tissue type. Okay, so these are called TARTs, TARTS. Okay, so you need to screen for male patients after 10 years of age. In adult patients, okay, they have gone through the phase of growing, okay, you still need to continue annual physical examinations with all these things, biochemical investigations, which is your blood investigations, to see whether your glucocorticoid and mineralocorticoid replacement are adequate. Okay. So what is the medical treatment in non-classic congenital adrenal hyperplasia, where there's partial hormone deficiency? Yeah. So usually, children and adolescents with inappropriately early onset and rapid progression of puberty, they will need glucocorticoid treatment. Okay. And adults, it depends on what kind of effects, the side effects the patient is having. Okay. So women with hyperandrogenism or infertility, males with TARTs or adrenal tumors, they need to be started on glucocorticoid treatment, and they might be able to stop treatment when height is achieved or symptoms have been resolved. So again, it's a case-to-case basis. And remember to give stress dosing during periods of stress for the same reason as before. Okay? Now, genetic counseling, as we all know, CAH is an autosomal recessive disorder. So, there's 25% probability, 1/4, that each subsequent sibling of the index case meaning the patient who is diagnosed with CAH, will have CAH, and 50% probability that each will be an asymptomatic carrier. Okay, so it's very important that if one person is diagnosed, the siblings, the family is also be screened, okay? Based on the CAH incidence of 1 in 10,000, this is just an estimation from a paper, a parent with classic CAH would have 1 in 120 probability of having a child with classic CAH. Non-classic CAH parent has 1 in 250 risk of having a child with classic CAH. Now what we are very concerned about is classic CAH, right? Because the signs and symptoms are very much severe and requires lifelong medications most of the time. Okay, so if a patient is already been diagnosed with CAH, okay, is planning to get married, planning a pregnancy, genetic counseling should be provided because you do not want your partner to be a carrier as well. And if your partner is a carrier, what are the chances of you carrying a child with classic CAH? What are the risks? You need to be well informed of that as well. Okay. Managing long-term risks or complications of CAH. So, general things that doctors have to do, counseling regarding healthy lifestyle choices, okay? You need to do BMD, bone mineral density screening, because you know that these patients under prolonged glucocorticoid triggers, okay, they might have osteoporosis, they might have increased risk of non-traumatic fractures, okay? Testicular ultrasound periodically has to be offered to males to look for TARDs, and also because they have increased risk of psychiatric disorders, so behavioral and mental health consultation is also important. And also because a lot of patients, especially female ones, they would have ambiguous genitalia, right? Their appearance might look different from their peers, so they might develop insecurities in their life, psychiatric disorders, so this has to be addressed as well. And for males, if they develop precocious puberty, also this might affect their mental development, especially in young children. Okay, genetic reconstructive surgery, okay? It is not done in all centers. Certainly, I don't think so it's done in HSAS. Only in centers with experienced pediatric surgeons, neurologists, mental health professionals. It takes a big team to complete a genital reconstructive surgery, okay? Before the surgery is done, you need to have a lot of discussion with the parents or the index patient regarding the risks of the surgery, the benefits, the outcomes, okay? Now, in severely virilized females, early surgery should be done to repair the urogenital sinus. For minimally virilized females, sometimes observation is an option until the patient is much older. Okay, there are benefits of earlier surgery, as you can read there, and also later surgery. This is just to show you how it looks like in patients with mild and severe CAH. Yeah, I'm sorry for this. So if you look, this is an abnormal genitalia, right? There's a confluence. There's a common urogenital sinus, which is abnormal. Okay, so what the surgeons need to do, I can't show you because this is not working, but there shouldn't be a confluence over there. So what the surgeons can do is they mobilize, they separate the urethra and the vagina, which are two separate canals, and then they ligate as necessary. They repair the sinus connection. Okay. Primary adrenal insufficiency. Again, the causes you have to remember. So medical treatment, yeah, you give mineralocorticoid replacement, you give glucocorticoid replacement, you give androgens if needed. So this is also discussed in your STL just now, right? They lack all the hormones, so you just give them replacement, but you need to monitor. How do you monitor? Clinical findings. You give mineralocorticoid, you expect the BP to be normal. Patient is not dehydrated. You give glucocorticoid, they shouldn't have any hypoglycemia. They shouldn't be feeling lethargic and tired the whole day. So these are the clinical symptoms that you can monitor. Okay, and you can also give replacement in certain women with low energy levels, androgen replacement. Again, infants follow-up is very frequent, 3 to 4 months. Children and adults at least annually. And you also periodically screen them for autoimmune disease, okay? Prevalent in primary adrenal insufficiency patients, because some of them are of autoimmune origin, if you remember the etiology of primary adrenal insufficiency. So if they are of autoimmune origin, they are most likely to be associated with other autoimmune disorders as well. So you need to look up for that, whether the patient also has concomitant autoimmune thyroid disease, the patient has type 1 diabetes, the patient has autoimmune gastritis, vitamin B12 deficiency, a lot of the constellation of signs and symptoms associated with autoimmune disease. Okay? And management of adrenal crisis. So, if the patient comes to the emergency department, suspected of having adrenal crisis, right? So you immediately inject hydrocortisone to the patient, okay? And then you give fluid resuscitation because the patient lacks mineralocorticoid and glucocorticoids, right? So you give this immediately. Now, how do we recognize the patient? Some patients, they will have this kind of bands, okay? Adrenal insufficiency bands that they wear because they know they are such patients. So in the event that they appear unconscious to emergency department, the emergency department personnel can administer treatment straight away. So the patient education is important. They know that they might have precipitating events. Okay, they need glucocorticoid adjustment in stressful events. Some of the patients, mature patients,